Let's rock and roll and welcome everyone to the interface chapter. So, James, you want to start us out?
Do I? Oh, yeah, it looks like vacuolar.
It was a rhetorical question.
Right. Yeah, that's why I moved on. I will. Yeah, so vacuolar interface.
So there are vacuoles at the interface. What defines the difference then between vacuolar and lichenoid? So
with lichenoid, there should be like kind of a obliteration of the whole DJ where you can't even see definitively where it was in basal keratinocytes.
So in vacuolar, your basal layer is intact, just shot full of holes. Whereas in lichenoid, your basal layer is destroyed, giving you things like Savant bodies and squamatization of the basal layer and sawtoothing. So which one is this? Is that a rounded 3D or a sawtooth 3D with dead reds at the junction?
Sawtoothy.
With dead reds at the junction. So that makes it then lichenoid. And it's important because you're in a different differential then, right?
Correct.
So once again, vacuoles you see in anything interface. The difference between vacuolar and lichenoid interface is in vacuolar interface, your basal layer is intact with vacuoles. In lichenoid, it's destroyed with vacuoles. And evidence of destruction includes sawtoothing, dead reds, necrotic keratinocytes at the junction, mummified dead reds, which are Savant bodies. So, given that this one is lichenoid, what's your differential?
LP for this one. Could have also in the differential VLK, lichenoid GVHD, sometimes hypertrophic lupus.
Two more, I think you left out lichenoid drug and lichenoid regression of melanocytic.
Well, I wasn't considering lichenoid drug for this one because it doesn't have the other things that go with that. But I guess it can not have the parent thing where you can tell us that. Yeah, good point.
So, lichenoid drug, if you have EOs and parakeratosis, it's a good hint that it's not lichen planus, but you have definite cases of lichenoid drug that don't have EOs in your biopsy specimen. So, good to consider the whole lichenoid differential when we have cases. Well done. Okay, Jessica.
So this looks more like vacuolar change, I believe.
So your basal layer probably isn't wiped out with squamatization, but do you see necrotic keratinocytes?
I do.
You see lots of necrotic keratinocytes, right?
Yes.
And what's the time course of this eruption?
Well, it looks very acute because the horn looks very normal.
So the horn is completely normal basket weave, so it's probably pretty acute.
Yes. And so I'm trying to look to see if there's some dermal fibrosis or melanophages to suggest like a fixed drug, but
and I'm not sure I'm seeing any.
So I think like I would think about like a GVHD or erythema multiforme.
Yeah, and of those GVH, does that have an acute horn or a subacute horn?
Most often subacute.
Usually subacute, and this horn's pretty acute. So probably more EM to EN for this one. As you pointed out, if there were papillary dermal fibrosis here, which we're not seeing, or EOs or pigment around vessels, then you'd think of fixed drug. But this one, we have a hyperacute horn, interface dermatitis, dead reds. That's pretty good for EM to EM. And those two are indistinguishable histologically.
That's like technically in like the vacuolar category. So can you get like necrotic keratinocytes sometimes in the vacuolar?
You can, but you don't get savate bodies.
Not savate bodies. Okay.
You don't get sawtoothing, and you don't get savate bodies.
So it's kind of a dermal, kind of focal dermal infiltrate, kind of around the superficial parts of the hair, some cases. Definitely not a robust lichenoid infiltrate that I'm seeing now. I mean, it could be like a burnout lichenoid, or just a little.
Could be burned out lichenoid.
Maybe a little vacuolar. Some follicular plugging.
Tell me about your corneum. Kind of normal, then abnormal,
Okay, so there's a
at an angle with necrotic.
Yeah, so cornoid lamellae right there.
So there's a cornoid lamella, suggesting that this is.
Porokeratosis.
And the center of poro can look like anything. It can be psoriasiform, it can be lichenoid. So the key is noticing those cornoid lamellae at the edge.
So it looks like we have a kind of vacuolar interface.
So is your reedy pattern intact?
It is not.
So your reedy are
So it'd be
effaced,
lichenoid. Yes,
suggesting it's more lichenoid,
Right.
right?
So we have we're on hair-bearing area. Looks like see some sebaceous glands. I would so maybe some. Let's see. So is this like lichenoid regression?
Well, someone certainly took a big chunk of somebody's face, right? So they were probably after big game.
Right. I mean, it looks like
And
there's
this absolutely is lichenoid regression of
there's some
melanoma.
pigment at the periphery there. We can look down. So
And if you look here, there's maybe something subtle going on at the junction. The issue, of course, with lichenoid regression is immunostains usually don't help you because it's regressed, right? There's nothing there to stain anymore. So if the clinician's suspicion was Lendigo maligna, and you're looking at a broad piece of sun-damaged skin, and you have a lichenoid infiltrate, you are quite likely dealing with lichenoid regression of melanoma.
So looks like vacuolar to me.
So you certainly have something going on at the junction. It looks vacuolar. And what do you have here in the dermis?
More infiltrate.
Yeah, and those are lymphs, right? Just black. These things have vesicular nuclei and cytoplasm with no intervening collagen. Suggests that it's a granulomatous process. So you got a mix of inflammatory patterns. What kind of things give you mix of inflammatory patterns?
I'm not sure.
So you always think of drug when you see a mix like that. You think of various viral conditions when you see mixes like that. You think of syphilis when you see mixes of inflammatory patterns. And then occasionally lymphoma in the T-cell lymphoma group. This particular one was a drug eruption in an HIV patient with a mixed inflammatory pattern, but at least it gets you to that that mix. You know, mixed patterns gives you a differential with drug sort of at the top.
Alright. So some slender acanthosis.
And I'd say some are slender, some are fat. They certainly vary, right? And the intervening, so is the intervening epidermis fat, or is the intervening epidermis skinny, and all the thickening relates to adnexal structures?
Yeah, I agree with that statement.
So probably the second one, which is what's characteristic of pseudoepitheliomatous hyperplasia. So in PEH, the surface epidermis really doesn't take part in it much. It's all the adnexal epithelium that thickens.
I'm not seeing a real robust interface.
Yeah, not a whole lot of interface. I do see vertical streaking of collagen.
Yeah. Kind of looks like LSC a little bit. In there.
Yeah, so there definitely is a lot of secondary change here, a lot of LSC. Focally, a little bit of interface, not much, but you basically have a lot of secondary change here. You also have a lot of scar underneath. So this is something chronically picked and scarred. Then we'd have to dive a little bit to get to the primary process. The point of the slide is mainly primary versus secondary changes. All the LSC things being secondaries. So, well done. Okay, Dan, what do you see?
Looks very lichenoid.
Looks lichenoid. Imagine that in this chapter. Okay. So you have effacement of the reedy pattern, sawtoothing, loss of your basal layer, savat bodies, dead reds, interface change. I don't see para. I don't see EOs. So what's your differential?
So it's just either licoplanus or lichenoid drug.
Yeah, I mean your differential is still everything in the lichenoid differential, right? So LP drug, benign lichenoid keratosis, lichenoid regression of a melanocytic lesion. It's not particularly sun-damaged skin, and it's not particularly broad, so I think we can rule that out. Hypertrophic lupus is still in there. It's not particularly glassy. That usually is. Doesn't really look like an acral site where that usually takes place. But you have to run pretty much through your whole lichenoid differential. Oops, and I apologize. We may have been ever so slightly out of focus for those online. I got to keep an eye on the focus up there. A little bit faded. We're going to skip that. Let's skip that and continue.
Lichenoid.
So, lichenoid interface.
Thick band along the junction there, and some like adnexal involvement too.
Okay. And we're looking at the corneum. Corneum's sort of subacute.
Sure.
So suggests with about half the corneum being red, this lesion's been around probably for about 2 weeks or so. Takes about a month for the full corneum to turn over, although it varies a little bit by body site. And when you look around, there are a few cells like that with a bright red rim. And then here, like they're EOs. So lichenoid with EOs. Lichenoid drug, especially given that it's a subacute corneum. EOs present. Both of those things are pretty good for lichenoid drug eruption.
It looks like it could possibly be on acral skin.
Looks like we're on acral skin.
We have obscuration of the DEJ, superficial and deep, perivascular infiltrate, and peri. There are no nexus. I feel like with
that distribution and that location to think about lupus, hernia, or not lupus, think about lupus or hernia.
So lupus or pernio, and a third of perniosis is the presenting sign of lupus. So, and you're absolutely right, you're spot on, that's what this is. So you have a lichenoid interface, and you're a little bit deeper with your infiltrate. And when you look at the vessels, it's a little bit of white, a little halo of white around every lymph, a little papillary dermal edema, which is great for perniosis. That's the so-called fluffy edema of perniosis. And so this is perniosis presenting as the first sign of lupus, so-called Chilblain's lupus. One of the hints to where you are, you got the thick corneum, you also have a little glomus body right there. Not a glomus tumor, but a normal physiologic glomus body, which puts you on the side of the digit.
So, well done.
So, see lichenoid infiltrate. The streptoconium, there's a lot of it is orthokeratotic. There's maybe some focal areas of perikeratosis. There's substantial pigment incontinence and melanophages, and there might actually be melanocytes in there as well. And yeah, actually, a large majority of those are actually melanocytes.
Yeah, so you got a nevus, and then you've got lichenoid interface.
So it's not quite a like a halo nevus. Certainly, you'd want to think of lichenoid regression in melanoma. I don't really see like confluent melanocyte proliferation along the DEJ.
I
And
agree.
The overall architecture is of a banal nevus, so it could just be it's still a lichenoid kind of response to a nevus.
Yeah, or just a twofer. Two unrelated diagnoses hitting at the same spot. So lichenoid regression of melanoma tends to be a broad biopsy, effacement of the reedy, sun-damaged skin. Everything's very flat. This is a bump with the nevus. So you're absolutely right. I think the two are unrelated processes. You got the nevus there, and you got the lichenoid infiltrate, but probably not lichenoid regression of melanoma.
So off the bat, you have some sort of vesicle with necrotic keratinocytes.
Yep.
The inflammatory infiltrate for that amount of necrosis is not what I would expect. It's a little less.
Okay. So necrosis out of proportion to lymphs.
So I'd be on the EMTN
So from scan,
spectrum.
you've got an acute corneum, you've got death and squalor out of proportion to lymphs. That's pretty good for EMTEN, right? Let's go a little higher.
There are a lot of EOs. So
A
it
lot
could
of
be,
EOs. Do you
it
see
could be
that?
drug,
So, and what kind of drug?
just like a bullous lichenoid drug.
So bullous lichenoid drug, but bullous lichenoid drug tends to be an acute corneum or a subacute
No
corneum?
subacute.
And this is a very acute corneum. Let's look over here. I see interface. Our focus is drifting a little bit on here. I'm not sure why. But okay, so pretty acute corneum. Interface with dead reds. Lots of EOs. What's that brown stuff?
It could either be melanin or it could be hemosiderin.
Yeah, probably melanin. Yeah, you can always go a little higher. Do your fine focus. If it's non-refractile, then it's melanin. And did that melanin just recently fall out of this epidermis, or did it have a long time to take the bus
It had a
all
long
the
time.
way down to that vessel? Yeah, it had time. The bus came, picked it up, took it to the vessel. So that's a long time process to get the melanin all the way down there around the vessel. And yet, my corneum is acute. That doesn't make any sense, right? A super acute corneum and pigment all the way down around the vessel?
It does if you have a drug reaction that occurs at the same spot.
What kind of drug reaction occurs at the same fixed spot every time?
Fixed drug reaction.
Exactly. So you've got an acute corneum, necrosis out of proportion to limbs. Looks kind of EM-like, but you go to higher power and you notice lots of EOs, so it's a polymorphous infiltrate, whereas EM tends to be lymphs only. There is pigment down deep around the vessels. And what about all of this bundled collagen above the postcapillary venial? There's papillodermal fibrosis, right? All of those suggest you've had something multiply recurrent in this area. Acute corneum, chronic changes in the dermis. So your corneum, hyperacute basket weave, chronic changes, meaning papillodermal fibrosis, pigment that's had time to get down around the vessels, polymorphous infiltrate, fixed drug. Well done.
It looks like a lichenoid interface.
So lichenoid interface.
Very, very large piece of tissue.
Very, very large piece of tissue. So lichenoid interface with a very, very large piece of tissue makes you think what? Lichenoid regression of melanoma. You know, that's one of the hints. Now, does that mean no one will ever take a punch out of that? Of course people will take a punch out of it. So you have to be careful. Sun damage, facial skin, lichenoid. Certainly never called benign lichenoid keratosis on the face. Lichenoid AKs do occur on the face, but always be careful about lichenoid regression. And here we have some large melanocytes at the junction, poorly nested, hyperchromatic as a hint. But most of the melanocytic lesion will be regressed, so you won't typically see it. Okay, Paige.
I think this looks somewhat lichenoid.
It's certainly interface, right? Are the reedy sawtooth or are the reedy still
I
round?
guess they're still round. So more
Reedy are
vacuolar.
still round, so it's more vacuolar. And if it's vacuolar, then the next step is, do you have lots of holes out of proportion to lymphocytes, or is there basically a lymphocyte in every hole?
I think there's pretty much one in every hole.
So a lymph in every hole, and what are all these red things?
Is that red cell extravasation?
So there's red cell extravasation, and there are erythrocytes within the epidermis.
Mm-hmm.
So there's transepidermal elimination of erythrocytes, red cell extravasation, a vacuolar interface with a lymph in every hole. What are you thinking?
Or maybe like pleva?
Yeah, or pityriasis lichenoides. Pleva tends to have a scale crust over it.
Mm-hmm.
PLC, pityriasis lichenoides chronica, tends not to have the scale crust. So this is maybe a little more PLC-like, but pityriasis lichenoides is exactly where this fits. So what's your differential of a vacuolar interface with a lymph in every hole?
Mycosis fungoides.
Yeah, so, lymph in every hole, vacuolar interface, your differential is MF, 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 MF. And then after that, pityriasis lichenoides, early evolving phase of a benign lichenoid keratosis, and then syphilis and drug can, kind of fill out that differential. And the red cell extravasation is a big hint to pityriasis lichenoides. Okay, Rachel, what do you see?
It looks like I'm seeing
more of a lichenoid interface.
So interface, and in some areas it looks like you got sawtoothing. Not a
Yes.
very dense band.
There's some deeper infiltrate as well.
And most lichenoid processes have a fairly a fairly chronic horn that's compact. This one's awfully basket weave, right? Suggests that this is a very acute process. So that's a little bit odd for LP or any of the lichenoid things to have a very, very acute horn. So let's look at other areas, and in other areas my reading are more preserved. So there are a lot of necrotic keratinocytes, certainly enough that it looks like they're sawtoothing, so I don't disagree with you at all. But my corneum suggests it's a pretty acute process. So pretty acute process, interface, lots of dead reds all over the place.
Maybe like a lichenoid graft versus host, or
So lichenoid GVH, usually a subacute horn, and usually some background disorder and atypia of keratinocytes, but it's an excellent thought. So GVH in its acute phase is never lichenoid. Lichenoid and sclerodermoid are both manifestations of chronic GVH. Here your acute corneum is a little bit against that. Might push me a little bit to an EM to EN look, but I'd want to be very careful about correlating clinically because it really does look kind of sawtooth. So you got a little bit of a disconnect in how much sawtoothing you have, but with your acute corneum, lots of dead reds. If the history were right, and in this case the history is good for erythema multiforme.
okay.
Just sort of extreme necrosis mimicking lichenoid sawtoothing.
Lichenoid infiltrate, perivascular, periadnexal infiltrate as well.
Lichenoid interface, and you also have some perivascular, periadnexal, which always makes you think possibility of drug lupus lymphoma when you see that.
More of a subacute horn. There's some pigment incontinence.
Yeah, subacute. I mean, some areas it's been going on a little bit. You go out more towards the edge. Definitely more acute out here, right? Interface, dead reds. Where's the pigment?
It's deeper, so at that point you're thinking, more fixed drug, like in that kind of.
And you've got nice straps of collagen in your papillodermas, which don't belong in a normal papilloderma. So you definitely have papillodermal fibrosis. You've got pigment deep around the vessels. You've got an interface process. So probably fixed drug if your history's right. And that was the history. The one red herring in that one was that your horn's a little subacute, so it's probably a later biopsy of a fixed drug. The guy, it took you 2 weeks to get him into clinic. Or
So this looks like total obliteration of the deej there. So I'd call it lichenoid.
So a lichenoid interface, and
It's big, so melanoma.
it's big, so you would think of melanoma. In this case, they didn't actually find melanoma.
Probably used to be melanoma.
This was big because they were pretty sure it was a basal cell when they scooped it off.
LPLK.
So it could be a BLK, and one of the hints to a benign lichenoid keratosis, same thing as lichen planus-like keratosis, so BLK or LPLK, same thing, is your corneum tends to be mixed. So you look at different areas, and the nature of the corneum changes. In some areas it's crusted, some it's parakeratotic, some it's looser, some it's denser. That change in corneum across the surface is a hint to be okay, whereas most other lichenoid processes, the corneum's pretty uniform from left to right.
You have a punch biopsy. Looks like there's a lymphoid infiltrate in the papillodermis, and appears to have some vacuolar change.
So vacuolar change. And are you seeing lots of vacuoles without lymphs, or is there a lymph in every hole?
It looks like a lymph in every hole.
So lymph in every hole.
And with the epidermotropism, I would think about possibly MF.
So there's a lymph in every hole, and how big are those lymphs compared to the lymphs down below?
They are bigger.
They are bigger. So they're big, they're dark. If you look at high power, you'd probably see that they're notched and angulated. They tend to tag along the basal layer. Your corneum is a little bit compact, suggesting this has been going on for a while. This is not an acute process. You have papillodermal fibrosis, shifting the superficial papillary plexus, subpapillary plexus downward. And when you look at the infiltrate around the vessels, is there a lot of infiltrate on the underside of these vessels?
No, there's
Or is there more infiltrate to the top of the vessel, but really not much infiltrate under the vessel? That is your bare underbelly sign. So, MF, lymph in every hole. The lymphs in the epidermis are larger, darker, more angulated than the benign recruited lymphs below. Papillodermal fibrosis, compact corneum, bare underbelly. Most benign infiltrates, the perivascular infiltrate is symmetrical, a circle around the vessel. In MF, it's distinctly to the top of the vessel, towards the epidermis, with a bare underbelly beneath the vessel. So one more time. Interface dermatitis, lymph in every hole. The lymphs are larger, darker, more angulated than the benign recruited lymphs below. There's papillodermal fibrosis, compact corneum, bare underbelly.
Looks like a pretty big specimen here. Or punch biopsy. The horn kind of varies a little bit. There's like some follicular plugging there in the middle. Another cornoid lamella, perhaps.
So you did it exactly the same as you did last time, where you started with follicular plugging, then you noticed all the dead keratinocytes and the angle, and said poor keratosis. Very good. And we're going to keep giving you Poro until you know.
Let's see. So it looks like we have a vacuolar interface.
So vacuolar interface, so your redi are not sawtooth, they
Right.
remain round.
Intact.
And do you have lots of holes out of proportion to lymphs? Or is it more lymph in every hole?
Mostly lymph in every hole.
Lymph in every hole.
So, looking for. I guess your differential for lymph in every hole would be like. You would think about MF.
So lymph in every hole is MF, MF, MF.
Right.
Early evolving benign lichenoid keratosis,
Right.
pityriasis lichenoides, syphilis, and then sometimes drug.
Right. So, I mean, when I look here, I don't see any red cell extravasation.
I
So-
agree, no red cell
so I think that one's kinda
extravasation.
off the-
Let's look at the infiltrate. Is there a whole lot of infiltrate below that vessel compared to the amount of infiltrate above the vessel?
It's definitely more above it, so the bare underbelly sign.
Yeah, so you got bare underbelly sign around the vessels. You have papillodermal fibrosis. The lymphs in the epidermis, I'd say, are pretty large and dark compared to the smaller lymphocytes below. So your diagnosis?
MF.
Mycosis fungoides.
Very good.
looks like a pretty thin shave, pretty sparse interface. The redi are intact. I'd say perivascular infiltrate. Looks like a lens.
Agree. What's right there?
Coronoid lamella.
Coronoid lamella. Center of poro can look like anything. Always look at your infiltrate at the side.
Alright, so this one looks like a lichenoid interface. Looks like you have sawtoothing.
So sawtoothing, it's lichenoid.
Wow.
Here, your pigment pretty high. Really not much pigment down around the vessels. So more like a acute or subacute lichenoid process. Tell me about your corneum.
It's focally acute.
So it's basket weave. Tell me about your corneum.
Subacute.
So why is it different from one side to the other? Why is your corneum changing? Is there any lichenoid process that tends to do that?
BLK.
Like benign lichenoid keratosis. So that's one of the helpful clues to a BLK.
So it looks like we have ocular interface.
So you got an interface dermatitis. Tell me about your corneum.
Looks, again, areas are acute and areas subacute.
Although
But-
I don't see a lot of compact red here, so I'd say pretty acute across.
Okay.
Tell
Looks
me
like
about
we're-
where your pigment is.
It's down towards the vessels.
So pigment deep around the vessels, acute corneum, interface process. What are you thinking?
Extra.
Fixed drug. And you nailed that from scan without even seeing the EOS. That slide is dead, unfortunately.
Shape here. Is that cornoid lamella?
Yes, indeed, it's a cornoid lamella. Very good.
So usually with a lichenoid interface, I can see all kinds of dead reds from the scan.
So lichenoid interface.
Pretty broad biopsy. I feel like right now I'm just in the lichenoid differential.
Yeah, lichenoid differential, but with a pretty broad biopsy on sun-damaged skin. What might you include?
Lichenoid MM.
So lichenoid regression of MM would definitely be in your differential for this one. And, history, don't know on that one.
So this would fit into the lichenoid differential as well. There's
Lichenoid differential, tell me about your corneum.
it's got some serum crust and para, or either para or just serum crust and nudes.
And in areas,
Yeah,
it's
all
basket
thirds.
weave,
Yeah, so leaning towards BLK.
which is what the history was on that one.
I'm in the lichenoid interface because you have some sawtooth looking reedy.
Yeah, and why is there so much PEH? Your surface epidermis isn't really participating, but your adnexal epithelium certainly is huge. So pseudoepitheliomatous hyperplasia in a lichenoid process. What's your differential?
Syphilis, hypertrophic lupus,
And
LP.
hypertrophic lichen planus. Any way to tell the difference between hypertrophic lichen planus and hypertrophic lupus?
DIF.
DIF would be golden. So DIF is not positive in every case of lupus, but it is strongly positive in every case of lichenoid hypertrophic lupus. So you're never left guessing for those. So definitely interface, right? And I'm not sure I can make out if they're sawtoothing or not. Tell me about my corneum.
Looks pretty compact in that area.
Is it all the same, or
No.
does it vary?
Very.
Varies, which could be a hint towards BLK, so it's kind of compact, varies a little bit, and BLK, when it's well established, looks like lichen planus. Early on, its interface with a lymph in every hole. This one's kind of in the middle, which is kind of the life of a BLK. It could do that. Let's see. I'm going to get some good stuff here.
There's interface. I think maybe more of a lichenoid.
So definitely interface process. Looks in some areas like it's sawtoothed. Are there a lot of lymphs?
Not really.
How much depth for the amount of lymphs?
Not much.
So
It's out of proportion to
out of
lymphs.
proportion. So depth out of proportion to lymphs. Your corneum,
Is that acute?
or I'd say basket weave there. So pretty acute.
So like EM or TM?
Like EM or TEN, exactly. Step back for just a moment, look for any changes. Anytime you're going to say EM, TEN, look for changes of fixed drugs. So any papillary dermal fibrosis, no. Any EOs, no, just lymphs. Any pigment down around the vessels, no. So all is well for EM, TEN. Okay, Rachel.
Okay, so we've got a very superficial shave.
Yep.
Looks like acral skin. And then there's a coronoid lamella.
And there's a coronoid lamella, so poro.
This looks like a vacuolar infiltrate.
Vacuolar in some areas, though, is your...
Yeah, I know you have destruction of the DJ.
You have
there,
destruction of the basal layer. So in some areas, at least, it's made it to lichenoid.
You do have a subacute horn and some hypergranulosis over that area. There's some eosinophils as well. Be nicely pointed out, thank you. And there's necrotic keratinocyte up there I saw as well on the other spot. So you'd favor lichenoid drug reaction in this.
Yeah, this would not be bad for an evolving lichenoid drug, kind of subacute process, EOs present. History for this is it's someone after autologous bone marrow.
And you're favoring GVHD in that situation?
GVH you can get with autologous, although it's certainly more common with allogeneic. This person did not have their liver functions going up, did not have diarrhea, so there is also the eruption of lymphocyte recovery, which is just when you're engrafting, and it's described as looking like grade 1/2 GVH without the liver involvement, without the gut involvement. I think that came up at Grand Rounds, that discussion. And, the key is distinguishing eruption of lymphocyte recovery, which is benign, from graft versus host, which is not benign. And the keys would be the grade of the infiltrate. This, never has much going on at the junction. And the lack of any GI involvement, lack of liver involvement.
And could you do it time course-wise? Is acute GVHD even a little bit later on in engraftment, or not really?
It's usually right at the point of engraftment, whereas GVH then persists thereafter.
Oh.
Yeah, you are correct. So it's clinical pathologic correlation.
What are your thoughts on satellite cell necrosis and
You can
specificity for GHD.
non-specific. The words are certainly used when describing GBH, but there's no specificity to the histopath finding.
So I think this is lichenoid drug.
Do you see any ES?
Confirmed.
Yeah, nothing but. So you think it's lichenoid drug. Tell me about your corneum.
Pretty vascular weavy.
Pretty basket weavy. And why do I see some pigment all the way down there?
It's pretty...
And why is there
pointing,
papillodermal
but,
fibrosis up here?
In that case, I'd go with fixed drug.
Go with fixed drug. Very good. So difference between lichenoid drug and fixed drug. Lichenoid drug, usually a subacute horn. Fixed drug, usually an acute horn. Papillodermal fibrosis, strap collagen above the postcapillary venule, only in fixed drug, and deep pigment. Very good. How are we doing time-wise? We're at about the pace we want now. And we want to get through 75 to 100 slides per hour.
20 months in.
So you have a broad shape here. Not much infiltrate that I'm seeing.
Tell me about your corneum.
And yeah, you have a corneum.
Give him one more. Poor expert.
So punch biopsy, compact, sham corneum,
Reedy sawtooth or reedy intact?
Reedy's intact, it's kind of rounded. Vacuolar interface, looks like lymph in every hole.
So vacuolar interface, lymph in every hole, corneum?
It's compact. I don't see any reds, extravasated reds, nothing like MF. It's likely.
So corneum compact, whereas in Pityriasis lichenoides acuta, it's a scale crust, and in PLC, it's subacute horn usually. And that people get confused with that, even though chronica is in the name. The whole course of the condition is chronic, but every lesion is transient and evanescent. Right. And you certainly have a lymph in every hole. We could look a little closer to see if those lymphs are larger or darker than the lymphs below. If there's papillodermal fibrosis, you certainly have a little downward shifting of your superficial subpapillary plexus, suggesting there's papillodermal fibrosis there. Strap-like or linguini collagen. So you are correct. Mycosis fungoides from scan. Where is this one, Rob?
Yeah, so this one's
Is a little faded.
This one is less acute of a horn.
Tell me about the horn here.
So we have some para, or this newts.
So newts sitting on top of para, sitting on top of normal, sitting on top of compact
okay.
with para, kind of sandwiched. Newts para, newts para.
It's just, I was trying to think of what would be.
So what gives you sandwiching? Newts para, newts para.
Psoriasis,
Psoriasis.
yeah.
Very good. This is next week.
Different chapter, okay.
That's okay. On the now, when you take the board exam, fortunately, they will on every slide tell you what chapter it's coming from. They have that arranged for you.
That's great. Thank you for making that happen.
But for the rest of everyone else, where you don't know, actually, it's really great for us at Sign Out because they also tell us what chapter each slide is coming from at Sign Out. But for anyone else, it's good to think outside.
Yes.
I don't see any sawtoothing.
Don't see any sawtoothing, so then
Say
you'd say more vacuolar.
Looks like dead red.
Those are erythrocytes.
Oh, okay. So I would think Pleva or PLC.
And I see a scale crust, kind of a dirty scale crust with neutrophils.
So is that PLC?
It's
Pleva?
Pleva. Okay. Also keep syphilis in your differential, because syphilis will have a scale crust, syphilis has elongation of the rete, syphilis can have an interface dermatitis, usually not the red cell extravasation. So the red cell extravasation here is a pretty good hint. Let's just find focused a little bit. The red cell extravasation, pretty good hint for Pleva, but that would be my differential here, would be pityriasis lichenoides versus syphilis. You've got a scale crust, you've got elongation of the rete, you have a lymph in every hole interface pattern, you have red cell extravasation. I'd look for plasma cells, I'd look for endothelial swelling, I'd look for an interstitial busy dermis. In this case, I see all the lumens to my vessel. That's more Pleva. The other thing that helps differentiate, if you have Pleva, you usually have neutrophils packed in the vessel lumen. Whereas in syphilis, there usually is no vessel lumen because of the endothelial swelling.
No specific one.
Alright. So this looks lichenoid, it just looks obliterated. A lot of scale crust on top.
Lots of scale crust.
Pretty robust interface though. Right.
How about, tell me about your dermis here.
Busy.
It's awfully busy, isn't it? That is one busy dermis together with an interface process and newts in the horn. How about, do you see neutrophils in the vessel lumen? In fact, you see a vessel lumen.
Well, we're thinking syphilis.
This is raging syphilis. And if you look higher, you have plasma cells in this one, but 1/3 of cases of syphilis don't have plasma cells. Unless you think it's acceptable to let 1/3 of your patients get tabies, then you got to look beyond plasma cells. But scale crust, interface process, busy dermis, endothelial swelling, syphilis.
Is that mucin or is that just edema around that nexus?
Edema in this case. You could always stain it if there's a question.
So this looks like a shave with some interface.
So vacuolar, or are they sawtooth with some hot bodies?
The latter.
So probably more lichenoid interface. Tell me about your corneum. Is it the same here and there, or is it different here and there? It's different. So probably if the history's right, that would be a nice clue for would be okay.
This looks like more of a vacuolar pattern.
So it looks more of a vacuolar pattern. Tell me about your corneum.
Acute there.
Yeah, pretty basket weave.
Yeah.
Tell me about your papillary dermis. Why is it so wide and so red and so ropey?
Looks like there's some fibrosis. Yeah.
Some papillodermal fibrosis. Papillodermal fibrosis with an acute horn?
So fixed drug.
It's a fixed drug, and then that would suggest that all of these red things probably are not erythrocytes. They're probably EOs. Look for some deep pigment around the vessel.
So you have a pretty compact stratum corneum, nice sawtoothy lichenoid.
So it looks lichenoid. What are all these dark things up here?
Polypara.
Para. So what lichenoid thing is this probably not?
So it's probably not lichen planus.
Probably not lichen planus. And this one was lichenoid drug.
So most of the stratum corneum is vascular acute. Some areas have compact orthokeratosis.
So
So if
some
it's-
areas a little more compact, most of it basket weave.
So it's all drain, maybe hints BLK.
So maybe BLK depending on history.
There's some fibrosis there.
There's a lot of fibrosis. You can see real ropes in there, right? And how about the pigment?
It's pretty deep.
Pretty deep, so what do you think?
Fixed drug.
Fixed drug, very good. That's it. We're at the end of the session.
Wow.
Well done. So we got through 50, not quite 75, but we're getting there. That's what we want to aim for with the lightning round.
Another 18 months.